for the practicing urologist, it's a little different. There are some biomarkers that are at their disposal right now. There's an Oncotype-like test that's out there for kidney cancer, which uses a 16-gene recurrence score. These genes straddle various pathophysiologic domains of kidney cancer. It includes vascular genes, inflammatory genes, et cetera. And this gene score was validated across both a Cleveland Clinic and French-derived cohort, and it predicts risk associated with metastasis. So if you have, for instance, a patient with localized kidney cancer, you can get some semblance from this risk score about their risk for developing metastases down the line. For the medical oncologist, it's a little trickier. We do have some emerging biomarkers. So for instance, if you're running mutational panels, be it Caris or Foundation Medicine, et cetera, there are certain alterations that may potentially predispose to a response to VEGF-directed therapies, others that may potentially predict a response to mTOR-directed therapies. For VEGF, for instance, we think that there are alterations in a gene called KDM5C, which may potentially lend itself to longer clinical benefit from a VEGF inhibitor. There's also been some great research from Dr. Choueiri and colleagues from the Dana-Farber suggesting that if you have mutations in mTOR, TSC1, or TSC2, these are genes that are related to the mTOR pathway, that may potentially predispose to a response to agents such as everolimus or temsirolimus.